Hello everyone, and thanks for joining me for this webinar. We're going to go through a number of things, learning about obesity, learning about the factors that contribute to it, and then some about the consequences of obesity, and then of course the treatment options, and we'll be discussing mainly the surgery. So try and stay with me for the entire presentation. Please send in by chat or email any questions that you may have. My goal is to answer all your questions and to make you understand as much as possible about this topic. So let's get it on. Is bariatric surgery right for me? First of all, we start by defining what obesity is. Obesity, first off, is a disease. It's a disease of excess fat storage. And there's a number of associated diseases that we call the comorbidities. This is a progressive, life-threatening, and costly disease. Now, I want to focus our conversation on something called morbid obesity. This is the more severe, life-threatening, or medically significant form of obesity. What do we mean when we say morbid obesity? It's defined sometimes as people being more than 200% of their ideal body weight or more than 100 pounds overweight. The industry standard that is used is something called the BMI. The BMI is the body mass index. This is a number that is derived when you take the weight in kilograms and you divide it by the height in meters squared. That number, if it's above 40, falls in the category of morbid obesity. If the number is above 35 and there's the presence of the associated diseases that we call the comorbidities, then it's also morbid obesity. So here we see various levels of body weight, and a BMI between 18 and 25 over here is considered to be normal weight. BMI between 25 and 29 is overweight. Above 30 is where we start talking about obesity. And above 35 is severe obesity. And as I said, with the presence of comorbidities is morbid obesity. And then a BMI above 40 is morbid obesity regardless of whether there are present comorbidities or not. So what causes obesity? The main takeaway from this slide is that it's a busy slide. So there's a lot of factors that contribute to obesity. Okay, it's everything from a genetic predisposition, the fact that they found that genetic twins that were separated at birth, and they go to find them 25 years later, and their weights are within a certain narrow percentage of each other, no more than 3%. The fact that there are physiological factors like some hormones called leptin and ghrelin, which we'll talk a little bit more about as we go on. There's also behavioral factors, traditions, things like that contribute to obesity. Gender, because women have a higher fat component. And then socioeconomic factors, psychosocial factors like stress come into play in obesity. And then there's the societal factors. The fact that we've become more or less a sedentary society. A lot of my patients tell me they want to go back to work early after having the operation because all they do is sit at a desk. A lot of them commute long distances. I see a lot of bus drivers, school bus drivers, school teachers, the people who commute and they're sitting down driving. Even though you're moving, you're kind of sitting down. It's a sedentary thing. And after work, what do? You come back home and get on a couch and sit down some more. So this society is really sedentary now. And this is even more so with the kids. The kids spend a lot of time, not like you and I running about playing, but just sitting down on their device. So this is the sort of sedentary society we're in now. And there's also medical conditions. And sometimes it's the conditions themselves, and sometimes it's the actual treatments, the medications that is contributing to obesity. So these are a list of some of the medications that are weight positive that contribute to obesity. Some of them you might be expecting, psychological medications like mood stabilizers and things like that. But some other common things, like beta blockers for blood pressure contribute to obesity. Sulfonylureas that are used in diabetes contribute to obesity. So let's look at our modern environment and how it affects obesity. In the modern environment, what do we have? A lot of calorie-dense foods, manufactured foods, highly processed, with a lot of sugars, and then the lack of exercise, and the stress in the society, and also inadequate sleep, all contributing to obesity. And then, as I mentioned, the medications. 10% of obesity is said to be due to medications. So if we put all these factors together and try to summarize, the factors that contribute to obesity are genetic, behavioral, and environmental factors. So what are the effects of morbid obesity? So we can start with the comorbid diseases that we're mentioning. Disability, more medical costs due to the comorbid diseases, a reduced quality of life, and also premature death. Now, this is a science slide I'd like to take you through. This is the connection between obesity and the comorbid diseases. Now, we define obesity as an excess of fat cells. Now, those fat cells are not just sitting there. They act like an endocrine organ, always producing substances and taking in substances. They are more adept to holding on to calories than releasing calories. Okay, but they release other substances, and these substances are the link between obesity and the comorbid diseases or conditions that we see. For instance, they release angiotensinogen, and that has to do with high blood pressure. Stored triglycerides has to do with hyperlipidemia. Cortisol has to do with diabetes. TNF-alpha interleukin-6 has to do with the propensity to form blood clots. Leptin is interesting, because leptin normally is a satiety hormone. It's a hormone that tells your brain that you're satisfied. But when this is produced in excess, the effect of the brain is that it numbs the brain to its effect. It becomes a numbing effect, and it's not as effective like it used to be. Now, a lot of people will say to me, hey, Dr. Sean, I'm obese or I'm fat, but I'm a healthy fat person. Well, majority of people who are obese have some metabolic problem, okay? And that's what this shows here. So for men, about 71% of people that are obese have some metabolic abnormality, okay? For women, only 65%. It's less compared to the men, I guess, because for men, the distribution tends to be more central. Now, this is a list of some of the conditions that we see, the comorbid conditions that we see with obesity. Okay, and it's everything from the common things we all know, the diabetes, the high blood pressure, the hyperlipidemia, the sleep apnea. So some things that people might not take into consideration are due to the weight, like urinary stress incontinence, okay, menstrual irregularities, infertility, okay, gallstones, fatty liver, coronary artery disease, a very important risk factor that comes from obesity, and then cancers that are associated with obesity. Now here comes the disability. This is in terms of difficulties with day-to-day living. It's interesting for me as a medical doctor. I really was more concerned with the comorbidities and the diseases. But what my patients started to come back to me with, things like, oh, thank you, Dr. Sean, because now I can cross my legs. Things like, thank you, Dr. Sean, because, when I go into a restaurant, I don't have to worry about whether I can make it through the chairs to my seat, or whether they're going to put me in a booth and whether I'll fit. People have thanked me because they've been able to go to Six Flags, and as one of my patients said, rode the hell out of those rides in Six Flags. So sometimes it's the simple things in life, that if you're unable to do, turns out to be a big disability, which leads sometimes to some psychological problems. For instance, negative self-image, social isolation, I just don't want to go out anymore, I just hang in here and stay indoors all the time, that sort of thing. Discrimination and depression. So obesity also leads to shorter life expectancy. In the United States, about 400,000 deaths annually are attributable to obesity. And compared to people of normal weight, there's a 50 to 100% increased risk of dying prematurely. Okay, and obesity is competing with cigarette smoking as the #1 preventable cause of death in the United States. Now, as clever as we are, doctors were not the first people who noticed this link with obesity and mortality. The people in the life insurance business noticed that before us. So you see here, this is a mortality chart, and you see as the BMI starts to climb above 35, that line is not just increasing in a linear fashion, it's curving upwards, so it's increasing exponentially. Now, this is a big national problem because 65% of the adult population are overweight or obese, and 5% fall into that morbidly obese category. A third of the children are also overweight, and we're spending about $147 billion on this problem. So I just want to show you this chart. This is my sort of political blue state, red state chart. Actually, I'll give it away because my chart, the blue states are states that have only 15 to 20% of the population obese. If you see any state that is orange or red, that means more than a quarter, more than 25% of the population is obese. So this is a chart from the CDC from 1998. So let's take a look and see what happened over the next decade. Okay, and even Colorado at this time has actually turned red. So this is a national problem, and people try to boil it down to individuals and think, say it's like an individual thing, but that is not true. This is a national problem about the environment. There's something going on in the environment. One of the popular theories is that about 30 years ago, when the government saw the impact of cardiac disease, and they felt that was due to the fat component of the diet, they sort of instructed the food industry to reduce the fat component in the diet. And would you know, when you take out the fat in the food, it tastes like cardboard? So what happened was, as they took out the fat, they replaced it with sugar. And I know a lot of people know about high fructose corn syrup, a form of sugar that the body doesn't handle very well. And people think that this is part of the reason why we're seeing this problem today. The other thing we're going to have to face up with is the growing epidemic of childhood obesity. So how does our body regulate weight? If you look at this chart, it shows you that it's a very complex system through which our body regulates weight. There's a lot of nerves and hormones that are involved. There are stretch nerves here, that are stretch receptors connected to the stomach that have something to do with it. There's that hormone ghrelin that we talked about. There's also leptin that I mentioned earlier. There's a host of other hormones, peptide YY, GLP-1, and there's a lot of interconnection. So it's not a simple thing. The kind of inputs that we tend to think about or that are under our conscious control accounts for very little of the problem. Our brain regulates the meal timing, meal size, our energy expenditure in terms of our metabolism, and reproductive competence. So there's this concept of a body fat set point that would help us understand how the body controls weight. Now, the body fat set point is what your body sees as your normal fat set point, what your normal weight should be. When you gain weight, the body resets what that body fat set point is to that higher weight. so that the body now sees that higher weight as normal for you. And when you try to lose weight by dieting, by consuming less foods and less calories, your body responds with hormones that increase your hunger, that increase your cravings, that slow down your satiety and also slow down your metabolism. Now, this is because developmentally, as we evolved as human beings, the problem really was starvation. And we don't have any sort of control for the other extreme, which is obesity. So your body sees every time you overcome starvation and increase in weight, your body sees that as a positive thing that it wants to defend. So the factors that affect the body fat set point are genetic predisposition, environmental exposure, and developmental history. So this is an interesting experiment that was done on rats, and I'll give you the human equivalent after this. So these rats in the blue line you see here were allowed to just feed normally, or what we call ad libitum, as they desired. And then they took two sets of rats as well that were comparable, and they did two things. The red line here indicates the intervention period, and they monitored their weight in that period. And this is when they returned them to just allowing them to feed normally ad libitum. So for the first line, they took these rats and they kind of starved them. And you would see their weight went down, and then as long as they allowed them to start feeding ad libitum, the weight climbed back up to match those of the rats that they did nothing with. Now, the other set are the rats that they overfed for a period until that line, and they allowed them to then feed as they liked. So this is what happened to their weight. It increased, and then at that point, it dropped back towards the normal weight. So this tells us something, that there's a kind of set point for the weight that the rats always kind of came back to, whether they were underfed for a while or they were overfed for a while. Now, I promised you I'll tell you the human equivalent. So take, for instance, you went on a cruise, right? And this was a all-you-can-eat, all-included cruise. You know how you want to eat your money's worth in those things. So you eat and then you gain about 5 pounds. When you come back to your normal life, you would see how that 5 pounds would melt away without you doing anything special. So this is the situation there. So the brain controls what your weight should be. It's not necessarily something that we control under our own willpower alone. This is the other thing that I use as an analogy. Think of an escalator. When you try to go from this weight up here to a weight down here, just by exercising and diet, it's like going from here to here on the escalator that is going up, because your body recognizes that higher weight as your normal weight, and you're working against your body. The difference with weight loss surgery is when we perform weight loss surgery, it touches many points hormonally and metabolically along which your body controls your weight, such that the body itself wants to be the lower weight. So therefore, if you're doing this after surgery, you're going from here to here on the escalator that is going down. Now, let me just add this at this point, because we want people still to eat a healthy diet and to exercise. The surgery is not magical. So see that healthy diet and exercising as walking down the escalator as it's coming down. That metabolic effect of the surgery tends to last about 2 years. And after that, it sort of levels off. But by that time, people should have reached the low, more desirable weight. And what they do in terms of exercising and proper nutrition or diet would help them to maintain the new lower weight. Now, I get some patients who tell me, hey, doc, they're 1 year after their surgery, and they tell me, hey, I'm not exercising, I'm not even eating right, but I'm still losing weight. So those patients are relying only on the metabolic effect of the surgery. And two things happen. First of all, they don't get down in weight as low as they should have. And second of all, when about 2 years comes around and that metabolic effect of the surgery, which is separate from the anatomical effect of reducing the stomach. When that metabolic effect of the surgery kind of thins off, those patients are the ones that tend to now regain weight because they don't have a lifestyle in terms of their diet, in terms of exercising and physical activity that would justify the lower weight. So essentially, what are we saying? You have a vicious cycle here where there's weight gain, you go on diet and exercise to reduce the weight. The hormonal levels in your body, adjust to what you're doing and increase to give you more hunger and increased appetite so that then you gain the weight back. This cycle usually takes about 6 months. So bariatric and metabolic surgery helps you to break that cycle so that it adjusts the hormones and metabolic system in your body to favor the weight loss so that then you can sustain the weight loss. So how do we treat obesity? And this is a pyramid of treatment that I sort of suggest to people to kind of think about it in some sort of a logical fashion. So if the BMI is greater than 25, you're overweight, lifestyle modification with physical activity, behavior modification, and a healthy diet should be able to help. If the BMI is between 30 and 35 without any comorbidities, or between 27 and 29, medication may also be able to help in those circumstances in addition to the lifestyle modification. But if your weight is getting above the level of a BMI 35 to 40 with comorbidities or greater than 40, surgery is the only modality that we see that has been shown with evidence that's able to help people not only lose the weight, but to keep the weight off over a long period of time. So the contribution of diet, I know people say calories in versus calories out. It's not completely true because there's something in between there, which is your brain that has a lot of ways of balancing out the calories. We suggest low glycemic index foods, meal replacements sometimes we use as a temporary strategy with a proper diet. We also are proponents of a Mediterranean type diet, high in proteins, nuts, legumes, things like that, and avoid highly manufactured, highly processed foods. A daily calorie count of about 800 to 1200 is what we see with people losing weight. And the best diet is really one that the patient can sustain. Exercise, the recommendation is 150 minutes a week. We always recommend a kind of structured environment for exercise, and this is why in our program we've developed with the gym a program of exercise where there are small groups, all bariatric patients, and with a personal trainer who teaches them how to exercise. Number one, safely, and then number two, effectively. We give them routines and how to change them up, and it's all supervised in a structured environment. I always advise my patients that the first 6 months after weight loss surgery, that I'd like them to participate in this structured exercise program, because that first 6 months is when we see the greatest rate of decline in the weight, and putting a structured program like ours in that time frame will help them to maximize the weight loss. So medications for weight loss tend to fall into two main groups: appetite suppressants and something that prevents fat absorption from the GI tract. Mostly medical patients would lose about 7 to 10% of their total body weight, and this is regained once the medication is stopped. And this is not to mention the medication's side effects. So someone in the New England Journal of Medicine a while ago concluded that no current medical treatment for obesity reliably sustains the weight loss. And that's the key there, the sustenance of the weight loss. Because as I showed you, the problem a lot of people have is not losing the weight initially. And I have patients who've lost over the course of many years about 1,000 pounds. The problem is sustaining the weight loss. And that is because they're literally fighting against their own bodies. And the reason that weight loss surgery is successful in this realm is because it touches many points along which the body itself controls the weight, making the body itself want to be at a lower weight. So that's an introduction for surgery for morbid obesity. So what are the criteria for people getting surgery for morbid obesity? Well, some clever doctors came together in the NIH in 1991 and developed these criteria. These criteria are important because a lot of the insurance companies wrap their criteria for approving weight loss surgery around these criteria. And I'll show you some variability that the insurance companies try to apply, which to my mind is that they want to see ways in which they can avoid paying for the surgery. So it says you must have the chronic disease of morbid obesity. So chronicity implies time. So you must fall into that morbid obese category for a period of, say, 2 years. An insurance company will say you must fall in that category for 3 years. And that category of morbid obesity is defined by a BMI of greater than 40 or a BMI of greater than 35 with some of the associated diseases. So when I see patients, I try to gather as many of the associated diseases that they're dealing with so as to stack the deck. Failure of dietary management. Surgery must be a last resort. Patient must be fully informed, which is what we're doing right now. And then patient must be motivated to lose weight. And that motivation is part of the reason why a psychological evaluation is also required to qualify for surgery. So to flesh that out a little bit, there must also be absence of any kind of drug and alcohol problems and no uncontrolled psychological conditions. And the decision for weight loss surgery that candidates are appropriate must be a consensus by a multidisciplinary team. So our program puts together all these things for all our patients. The patient must be dedicated to lifestyle change and lifetime follow-up. I always state that, there's no magic bullet here with weight loss surgery. Part of the success is due to changing your lifestyle in terms of diet, in terms of exercise and physical activity. So let's look at different categories of bariatric procedures. First of all of them are restrictive in nature. Now we see that there's the adjustable gastric band is restrictive alone. Most of the way it works is by restriction alone. And this is part of the reason why there hasn't been a lot of success and people have moved away from the band. Now there's those that are restrictive and malabsorptive, the gastric bypass and the biliopancreatic diversion. However, what we've noticed that the strongest effects that these have is because they're not only restrictive, but they're also metabolic. They affect a lot of things along the pathway that your body controls weight, metabolic processes. Okay, and included in that is the sleeve gastrectomy, the gastric bypass, and the biliopancreatic diversion. We will discuss mainly the sleeve gastrectomy and the gastric bypass. So one of the reasons we've been able to do a lot more bariatric surgery in the recent years is because we do them minimally invasively. Okay, some things that may hinder us or make a laparoscopic surgery not so easy, not that it's easy at all, are these factors here. The presence of adhesions. Okay, if people are unable to undergo general anesthesia, you can't do laparoscopic surgery. Okay. Now, the other thing is abdominal compartment syndrome. This is a phenomenon. If you see that someone has an abdomen that looks like they swallowed a Volkswagen Beetle, then that is a concern for laparoscopic surgery because we need a space to work in. And we'll generate this space by putting gas into the abdomen. And this is the reason why sometimes we would ask some of our patients and put them on a diet to lose some weight before the surgery. This is allowing This allows their stomach to fall so that we can create a good space in the abdomen with the gas. And the more space we have in the abdomen during the laparoscopic surgery, the safer the surgery. Now, adolescents and the elderly. At this time, I don't operate on people less than 18 years old due to the facilities that we operate out of. The elderly, this has always been moving. And initially with the NIH, it was set as 55, and then people started talking about 60. I currently offer this if the patient's of acceptable physiological status after going through the multidisciplinary evaluation. Because you know there's some people who are 70 going on 50, and then there's some people who are 50 going on 70. So we just test them for their physiological status. Having said that, the oldest person I've performed weight loss surgery on was 75. When you get to a certain age, you gotta, say to them that, hey, listen, at 80 or so, you've lived your life, you've survived with the disease. There's no need to do this. So what are the surgical treatment options? So this is the gastric bypass. It's the second most frequently performed procedure today. The mean excess weight loss at 1 year is about 70%. And what do we mean by mean excess weight loss? That means if I weighed 300 pounds and my normal weight at the BMI of 25 would be about 200 pounds, the 100-pound difference is my excess weight. And if I'm an average performing Joe Schmo and I go on and have a gastric bypass, I should expect to lose about 70% of that 100-pound excess. That's about 70 pounds in 1 year. It doesn't mean that the weight loss stops after 1 year. It will continue. And it doesn't mean that that number cannot be overperformed or underperformed. It can be, depending on what you're doing with healthy diet, exercise, and physical activity. A lot of my patients actually outperform that number. It also treats acid reflux. The gastric bypass has a profound effect on diabetes, increases the level of that PYY and GLP. This is part of the metabolic effect that the surgery has. It also reduces ghrelin, which is the hunger hormone, okay? And it increases the metabolism. You know how people say that as you grow older, your metabolism kind of slows down? This surgery actually bumps up the metabolism. And it actually gives the patient an effect. When patients have gastric bypass, the body reads that as they are being overfed. So what the body does is that, thinking that it's receiving so much energy, it bumps up the metabolism to try and burn off some of that energy, okay? And that's the effect that we see. It's the same sort of effect in this portion of the graph that I showed you with the experiment with the rats that were overfed.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
So let's look at how the gastric bypass works. Number one is that it reduces the amount of food that is needed to feel full. Once we create this small pouch at the top of the stomach, that becomes the effective stomach. And filling that up usually gets full with about 4 ounces of food. The patient would feel full. That's because feeling full has something to do with filling to the top of the stomach here where it sends signals to your brain to tell you that you're full. Secondly is that it lowers the ghrelin hormone level, and that's the hunger hormone and the hormone that's also responsible for some change in appetite, especially for sweet and fatty things. So because this portion of the stomach that produces the ghrelin is disconnected, the ghrelin level drops, reducing appetite. Also, it reduces some absorption of the food consumed, because when we do the rerouting of the bowel and we connect this limb of the bowel to the pouch, the food coming through that limb has no digestive enzymes. And the digestive enzymes coming through this limb has no food. So not until down here where we reconnect it and for the rest of the way does the food get fully digested and absorbed, and that causes some malabsorption. This is more, by the way, for micronutrients and vitamins than it is for actual food. The fourth thing, as I described, is that it increases the metabolic rate. Advantages of the gastric bypass is that it can act sort of as a cure, quote unquote, for diabetes, because of the profound effect it has on diabetes, not just from the weight loss, but even before that, almost immediately after the surgery, the effect, because all this area that has to do with the hormones that have to do with diabetes and the pancreas is completely bypassed. And those levels of hormones that relate to that drop drastically immediately after the gastric bypass. So we see patients with diabetes who their blood sugar starts to normalize even before they leave the hospital, or sometimes by the time I see them 1 week after in the office, they're already off some of their diabetic medications. Acid reflux. Because again we do this rerouting and connect the small bowel here, small bowel is always peristalsing, always moving things along, acts like a sort of suction device here, preventing reflux up the esophagus. So people immediately after a gastric bypass that had severe reflux are relieved of the reflux. And this is one reason why we might want to push some patients towards a bypass as opposed to something else. Some of the disadvantage of the gastric bypass is there's limited access now to the rest of the stomach. It's one of the reasons why we want to perform an endoscopy before we do any of these bariatric procedures. The other thing is the risk of what we call an internal hernia, which is due to the rerouting. It's pretty uncommon. We see maybe about one a year. Now, especially that we use these reactive sutures to close the hernia spaces that we create when we do the bypass. There's also a risk of marginal ulcers, and this happens mainly with patients who smoke or use non-steroidal anti-inflammatories. Those are medications like Celebrex, Advil, aspirin, things like that. Now, after a gastric bypass, the diet, of course, is strict. There's some discomfort, some time to recover. It's a 2-night hospital stay with a gastric bypass, and we recommend about 3 to 4 weeks off of work. Not that people would be laid up, but this is time to make sure that you return to your full strength before going back to work. These are some of the possible complications with the gastric bypass and indeed other bariatric procedures. And the point I would really want to emphasize here is that I see what I do as not just performing a surgery like a technician, but we have a program of a lot of things that we do, that the sum total of putting those together is to prevent or eliminate the possibility of these sort of complications. And for instance, bleeding, we use staple line reinforcements, clips, and special fibrin glue that minimizes any kind of oozing. Leaks we check for at the time of surgery and the day after with what we call an upper GI. DVTs, PEs, and blood clots, we give a special blood thinner to the patient before the surgery. We have what we call the toys, or these incentive spirometers that we have the people do immediately after the surgery that helps them prevent any sort of pneumonia, as well as getting them up and walking within 4 hours of having the surgery. Wound infections we hardly see with the laparoscopic surgery. Marginal ulceration, I just mentioned, due to smoking and NSAIDs. Protein energy malnutrition we hardly see nowadays with the procedures that we perform, not as extreme or severe as prior versions of these procedures. We do see vitamin and mineral deficiencies, especially with the gastric bypass, because, as I said, the malabsorption that is caused is more for the vitamins and micronutrients than it is for regular food. For women of childbearing age, especially, we've got to watch out for iron deficiency, anemia secondary to iron deficiency. And this is because after a gastric bypass, you don't have the capacity to absorb iron the normal way, and sometimes even primary care physicians that are unaware would be giving the patients iron, but they just are not absorbing it. This is why it's helpful to keep in touch with your friendly bariatric surgeon, and we will give you a special kind of iron that contains what you need to absorb that iron. Internal hernia, as I mentioned, and then inadequate initial weight loss or weight regain. As I mentioned, the surgery is not magical and works very well in the setting of proper healthy diets, which we help you with. We have a full-time nutritionist in the office, and exercise, which again we help with in terms of our exercise program. This is not the surgery where you can have the surgery and then return to your couch and be throwing back the potato chips and think that everything will go well. So here's an example of a successful patient with a gastric bypass. And the secrets of his success: he went from 365 pounds to 195 pounds within 8 months. What's interesting to me, somehow he manages to retain the same kind of shorts. However, this is a gentleman that was at the gym a lot. He would come to the office with a notepad to see the nutritionist, and in fact, by the time he was done, asking questions of the nutritionist herself was exhausted. So let's talk about the laparoscopic gastric sleeve. So this is now the primary weight loss procedure that we're performing. In this procedure, we take out about 85% of the stomach. There's no device being implanted if you compare it to the gastric band. And there's no rerouting of the bowel if you compare it to the gastric bypass. We're focusing just on the stomach itself. The average or mean excess weight loss at 1 year with this procedure is 60%. So what are the advantages of a gastric sleeve? Number one, we preserve the nerve function of the stomach. There's fewer restrictions of food, especially if you compare it to the gastric band. There's less micronutrient deficiency, especially compared to the gastric bypass. And we don't have that dumping syndrome, which is something we see in about half of the patients with a gastric bypass. A dumping syndrome is when gastric bypass patients eat something that is rich, like a piece of cake, something that is very fatty, and all of a sudden all the blood rushes into the small intestine. As it hits the small intestine, they feel faint, they feel dizzy, they feel nauseous, sometimes throw up, sometimes have some diarrhea, and it's a really terrible feeling. However, it's a very good teacher that tells people not to do that sort of thing again. The gastric sleeve, there's no marginal ulceration in this procedure. And in this procedure, because we remove this excess portion of the stomach, we're removing that portion of the stomach that produces the hunger hormone ghrelin. So these are the patients that come back to me saying, Dr. Seun, I don't really feel hungry. I just know it's time to eat, and I eat because I know I need to eat. There are people who also have a dramatically reduced appetite, especially for the sweet things and the fatty things. And there's also that increase in those hormones, the PYY, the GLP-1. There's also increase of the satiety hormone, the leptin. Okay, This is a procedure that is good for patients who've had previous abdominal procedures where we could be worried about scar tissue in the abdomen, because we can get, as long as we can get access to the upper part of the abdomen and get access to the stomach, we don't have to be down in the lower part of the abdomen where all the intestines are involved with the scar tissue. Disadvantages of the gastric sleeve: less weight loss when we compare to the gastric bypass, even though there are newer studies now that show us that about 5 years out from this procedure, the weight loss with the sleeve and the gastric bypass are comparable. It's irreversible, because when we do this operation and take out this portion of the stomach and throw it in a bucket, there's no way we're going to be able to put it back. Might require a second stage, means that this sleeve can be converted into the biliopancreatic diversion procedure and duodenal switch from which it originally came, or it can be converted even into a gastric bypass.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy.
So how does the sleeve gastrectomy work? Number one, it reduces the amount of food that is needed to feel full. If you take the natural stomach as sort of drinking with a beer mug, then drinking with a sleeve is like filling up a test tube. And you can see how that quickly fills up to the top, where it sends signals to your brain telling you that you're full. The second thing is that removing this portion of the stomach significantly reduces the ghrelin level, thereby reducing hunger and appetite. So much so, one of my patients famously told me once he woke up from the surgery, the first thing he said to me was, "Hey doc, did you remove the gremlins?" The gastric sleeve does not increase or reduce the metabolic rate. So here are some possible complications from the sleeve. Again, always a possibility of staple line leak, even though less than 0.5% in my practice. Bleeding. Stenosis means narrowing of the sleeve, and the way we prevent that is by putting a tube alongside the left side of the stomach, and we staple along that tube, and that helps us to prevent narrowing the tube. And it also prevents us from getting the gastric outlet obstruction. Stretching of the stomach is something that can happen. However, the left side of the stomach that we're leaving behind is the least stretchable part of the stomach. Vomiting and nausea, we don't see a lot of vomiting at all, but nausea we do see around the time of surgery. We give medications for this, and usually by the second or third day, there's no more nausea. So here's an example of a patient who did very well with the sleeve. I've known her for about 5 years. She initially had the gastric band, and after having her 5th child, the band slipped. We took that out and then converted her to a gastric sleeve. She did very well, going from like 319 pounds to 155 pounds within the first year after the sleeve, and has done very well since. The secrets of her success You can see here she was doing 5Ks initially with her daughter, and then she went on to run a full marathon in 2014, and I guess that's the reason she feels comfortable in sticking her tongue out at you. So quick word on the adjustable gastric band. I haven't performed a gastric band in the last 3 years, and the reason is we saw a high failure rate, about 50% of the patients not losing any significant weight at all. And then the mean excess weight is in the 40s. It's the highest rate of reoperations. That means having to bring them back to the operating room to take out the band or to do something else. Usually when we do that, we mostly go to a sleeve or sometimes a bypass. The band is also something that needs very high maintenance, so it might not suit the lifestyle of a lot of people. So what can you expect after bariatric surgery? The diet is strict. We do give you a transition period from going from a liquid diet back to a regular diet. Capacity for food you can eat has changed. I do have a lot of patients telling me their eyes are bigger than their stomach. You may experience discomfort as the body heals, and the length of time to return to regular activities varies by patient, but we advise patients for the sleeve, give 2 to 3 weeks off of work. For the bypass, give 3 to 4 weeks off of work, just to give your body time to recuperate. It's not like you're going to be laid up or anything like that. Lifestyle changes are necessary to ensure success. So around the time of surgery, we may start some patients on the low-fat diet, on a meal replacement. We encourage exercising. Exercising prior to the surgery helps you to bounce back well from the surgery, helps to tune up your lungs and your heart. Liquids the day before surgery. We recently went to having all our patients do only liquids the day before surgery because we started to experience the phenomenon of the Last Supper. Nothing to eat or drink from midnight the day before surgery. And on the day of surgery, you meet with anesthesia. We start all the things that are part of our program, and then the surgery is performed. Most patients will wake up in the recovery room before going up to their hospital bed. Post-operative day 1 after the surgery, we do something called the upper GI, where you drink a dye. They take some pictures to make sure there's no leakage or blockage, and then we start people drinking. And once you're drinking and holding down everything you drink by the afternoon of that day, we get most patients home. For patients who are gastric bypass, we hold them over to the next day, doing all the same things, the breathing exercises, the ambulating and walking. By second day, they're okay to go home. So lifelong rules include things like eating your proteins first. The proteins is the quality foods that you want to get in first, especially now that you have a small capacity in the stomach. So proteins first, followed by vegetables, and if there's any room at all after that, then you can get in some starches. Drink 64 ounces of water a day and try and stay well hydrated. Exercise 30 minutes a day at least. We do recommend even more intensive exercise, especially the period 6 months after the surgery, because this is where we see the maximum rate of the reduction in the weight. Avoid snacking, take your vitamins and protein shakes, and then the regularly scheduled appointments with me and other members of the program. The benefits of weight loss surgery include an improvement or resolution of some of these comorbidities that we've mentioned throughout this talk. There's also the improvement in the psychosocial functioning and self-image. I notice this most in like young people. I've been privileged to work with a number of young people, and I remember this particular person who she came with her mom who had done the surgery for, but she always kind of like was withheld and had some sort of an attitude. But soon after the surgery, and she had seen how she was losing weight and everything, like when she came to the office, she jumped out at me. She was like, "Hey, Dr. Sean," and all that sort of thing. So it really allows people to come out of their shell and blossom, move from the sidelines of life into the mainstream of life. So it improves the quality of life, and it can also improve marital satisfaction. However, in some cases, if there was already discord in the marriage, it could lead to divorce. And this just shows the longevity of weight loss surgery. If you look comparing it to medical weight loss, people lose a bit of weight in the beginning, but then they regain it and sometimes more. And that's over the long term. But look at the green line here for gastric bypass. There's a dramatic drop in the weight in the first year. People do regain a little bit by the second year, but then they hold out that weight level, and this is out to 15 years. And if you compare it to the baseline, it's really significant. The purple line, by the way, is for a vertical banded gastroplasty. You could use it as a surrogate for the sleeve. So weight loss surgery can help you change your life by resolving or improving the obesity-related illnesses, decreasing the mortality risk, and improving the quality of life. However, you got to remember that the surgery is a tool, not something magical. It's a tool that you have to do, you have to use with the appropriate lifestyle changes. So what are the next steps? So we've now completed the initial first step of attending the seminar, or the webinar in this case. Some of you have already seen me in consultation, and what I do in the consultation is try to match what your medical profile is to the procedure that you're thinking of undergoing. And then we would help start you with the medical evaluations and clearances that are needed. And we'll also schedule you for nutritional evaluation, which is done in our office. We have a full-time nutritionist with us who's also a specialist in diabetes. We help to verify the insurance benefits and obtain insurance authorization. And also we require an endoscopy, which is a test where the camera goes down into the stomach. We want to make sure there are no problems with the stomach before we go ahead and start doing surgery on the stomach. And then comes the surgery, and then lifelong follow-ups, support groups, and all the other things that we have as part of our program. So thank you all for staying with me for this webinar. I hope it's been very informative for you. I do encourage you, if you have any comments or any questions, put them in the chat or email them to me. I'll be responding to all your questions. My aim here is to give you as much information as you need as regarding this topic. Thank you very much.